Well, hello there and good evening. I'm Dr. Randy Fink, and it is straight up 5 o'clock Central Time, which means 6 o'clock on the East Coast, 4 o'clock in the mountains, and 3 on the West. And there is one place that you need to be right now, and that is right here at Fertility with Fink. Tonight, live from Tulsa, Oklahoma, where I am visiting with my friends at the Missouri Center for Reproductive Medicine, MCRM, and I am here with my colleagues doing embryo transfers in Tulsa, where I come sometimes. Also see, I also go to St. Louis to see my friends at MCRM, and tonight actually is the first time we will have MCRM's Facebook online with us here. So very happy to have all of our friends from MCRM joining us tonight. If this is your first time being with us, this is Fertility with Fink, and it is your weekly chance to kind of hang out with me and talk about all those things that are important to all of us. And that would be things like getting pregnant. What does it take to get pregnant? What does it take to stay pregnant? All these things about women's health, pregnancy, and making our beautiful families. I am so happy to have everybody here with me. My day job, main place is in Pensacola, Florida at New Life Fertility. We also have offices in Mobile, Alabama, and Panama City. But as you can tell, I get around, and had a nice busy day today doing embryo transfers. In fact, just ran back into the hotel, and that's why I'm running a couple of minutes late here. I still have a big mark on my forehead from wearing a light right there as like a cyclops. But we're live tonight from the River Spirit Resort and Casino in Tulsa, Oklahoma, which is really a very beautiful place. Tulsa is a great town. All the folks who work at MCRM are really great people, and it's a real honor to be a part of your life and helping you get pregnant here to the folks with MCRM. And if you are one of my friends, one of my patients, one of my followers here from the Gulf Coast area, I will be back on back Wednesday night, back for Thursday, and we have another IVF cycle coming up. And of course, we talk to folks who are all over the country and are happy to see people from any place for a consultation. So you just have to reach out to us and let us know that you want to talk, and that's what we're here for. So, how was your week? How was your weekend? It was a beautiful day actually here in Tulsa. Really, really nice outside. Started off a little cold this morning, but then it warmed right up, and gosh, it was a nice day. So, oh, let's see what we got going on here. All right, let's say hi to all of our friends. Angela Sack, good to see you here this evening. I haven't seen you for a while. We've got New Life Fertility's Instagram here. This is my Instagram at Randy Fink MD. We also have as I said, MCRM, we've got LinkedIn, we've got New Life Fertility, and we've got YouTube all right here in the middle. I will say that we're a little battery challenged here on the Facebook side of things from this feed here tonight. So if we are going to probably have to wind this one up a little early, but we will continue on till the top of next hour, top at 6 o'clock Central Time, through our Instagram feeds. And again, that's New Life Fertility and Randy Fink, MD. That is me. And let's see who we've got joining us here. A special hello to the Bama gal, my mother. Thank you for being here this evening in Mobile, Alabama, along with Dad. Amber Jones, you are the first to join over here. Thanks for being here tonight. Hi, Rosa and Mrs. Pittman. Grace, nice to see you tonight. Marlena, Jazzy Poo, how are you this evening? Amazing Javier. We've got Easy Breezy. We've got Mija Emily. Hello there. And oh gosh, we got a whole bunch of people here on the Facebook side. So feel free to say hello, throw in your questions here. And by the way, if you have a question and I can't get to it during the show because towards the end things kind of start to happen quickly in terms of questions, I'm not always able to get to the end of it or get to the end of the list here. Feel free to email me and we'll get to those at the top of next week's show, which will then be live from Pensacola. And Oh, Amber Jones, Amber Guitar. Wow, I didn't realize you had another name. Hi, Amber from Gulf Shores. Jasmine, howdy. Okay, so here's the thing. Got a good question, and it is a good question. And the question was, well, look, I'm ready to come back and do another embryo transfer. Um, I had a baby about 3 years ago through IVF, and I found that we had endometriosis and that I also had a polyp. So, how are those things addressed? Do I need more surgery? Do I have to do something different? What's going to happen now that I'm starting out the process again for another FET cycle? And I think that is a great question. So, let's answer it. Well, so the first thing is, yeah, we know endometriosis can stand in the way of you being able to get pregnant. So, since you have that diagnosis of endometriosis, there is no reason to test for it again because it's not like it, oh, poof, it cures and it's gone. It probably continues to hang out. But since you had, I believe you said you had a surgical diagnosis, you had a laparoscopy to reach that diagnosis, I would not do a BCL6 or receptiva test because we already know that you have endometriosis. I would just go ahead and treat that. And how do we treat that? We treat that with 60 days of suppression medication in order to put endometriosis to sleep. And that takes care of the inflammatory response in the uterine lining, which means that really your odds of successful transfer are pretty much the same as anybody else. But I would go ahead and suppress for 60 days. Now, evaluating the uterine cavity is something that we will do by necessity anyway. That's a natural part. So we're going to make sure that you didn't grow back a polyp, that there's nothing else going on the inside that will prevent an embryo from implanting. Rosa asks, is a modified natural embryo transfer less successful in older women, or are they as effective as they are in younger women? So a modified natural transfer is where we let your own hormones take the front seat, as I like to say, which means that we give you a little ovulation induction to make sure that you're going to release an egg. Now, normally in a medicated cycle, FET, we actually, the medication we give you, we don't want you to release an egg. If you release an egg, that messes everything up. So what we're trying to do here with the modified natural is to get you to function naturally like you normally would during a regular ovulatory cycle. We want you to ovulate. As opposed to a medicated cycle where we are shutting everything down, giving you all of those hormones ourselves to keep you from making it. And the thought was, well, if you do that, then you're covering really all of the bases. You're getting rid of every variable, and it must be better, right? Well, it turns out that actually the data shows us that the modified natural transfer, or even a natural transfer in some scenarios, is at least as good as the medicated transfer. And there are some studies that show that they're better. Now, I happen to be a fan of the modified natural, so I really like them. Rosa, I am not aware of any data that says that some one of those is less likely to be effective in women based on age. Now, it certainly has to do with the ability of your ovaries to produce an egg. So for those who are perimenopausal, who may not ovulate, and certainly for menopausal women, and yeah, we can absolutely put an embryo into someone who's menopausal. There is, that's a different story. In that situation, I wouldn't expect a natural cycle or a modified natural to work. But for someone who is continuing to have regular periods, yeah, I don't think that there should be a difference there. Hi, Brandis. Nice to see you this evening. And Catalina, Easy Breezy says, do you think an abnormal uterine microbiome can affect implantation? Enough research behind it, you think? Well, I got to tell you, I'm a little dubious about that. The evidence is really not very strong that this microbiome, it sounds like it should be a big thing, right? But the data really isn't that strong that that doing testing and more importantly, paying for testing of the uterine microbiome it really is going to make a difference. Now, certainly, if there are abnormal species that are growing in the vagina, then that's something that we can often tell clinically. But doing a test such as an Emma and an Alice test, which tests supposedly the uterine microbiome, I have not, and in fact, the data really doesn't support that it changes outcomes. So I don't routinely recommend that test to folks because it's also pretty expensive. And while it seems like a good idea, it really hasn't proven its way to the forefront as far as I'm concerned. Over here on the Facebook side, Michael Lynn says, I'm a Dr. Rips patient hoping to do another IVF. I only got one embryo and we had our son 13 months ago. Can I start testing my AMH while I'm breastfeeding, or do I have to wait? So AMH is one of those numbers that shouldn't be affected. I say shouldn't be affected by those hormonal things. So I think it's certainly fine to go ahead and do an AMH blood test if you're breastfeeding. Now, if you're taking some hormones like birth control, then the AMH level can be artificially decreased. But breastfeeding should not have an effect on the AMH. And I would say, yeah, Michael Lynn, let's go ahead and do it. Let's do it. Now, we don't want to treat you. We don't want to do an IVF cycle while you're breastfeeding because the medications we use, two things. One, will affect the breast milk production. And secondly, would also go through the breast milk and create hormonal issues in the baby. So we want you to be done breastfeeding by the time we go to do another IVF cycle. But absolutely, you can go ahead and have an AMH drawn now. Angela asks, are you born with a uterine septum or can it just develop over time? Because how is it possible that 3 previous hysteroscopy doctors didn't see it and then recently past 2 hysteroscopies, a new RE did see it? Well, I would think most of the time we consider a uterine septum, which is a muscular band inside the uterus, to be something that is generally there. Is there such a thing as an acquired uterine septum? I would say, it's not impossible, but my guess, Angela, is more likely that folks looked into the uterus and either it was a very subtle finding, like it's a very, very small septum, or they may have looked and concluded by what they were seeing that in fact it was that you had a bicornuate uterus, which is a uterus that's kind of shaped like a heart. And this piece that going down the middle, well, if that's a septum, then this piece going down the middle is actually just a muscular band, and all you have to do is go zip, 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 and it disappears. Whereas if it's a bicornuate uterus, the uterus itself is just shaped like that, and it's not a muscular band that you can kind of just cut through. So I think it was probably most likely one of those 2 issues, Angela, if I had to guess. Let's see, only Eileen. Well, hello, Eileen, if you are still there. Very nice to see you. I haven't seen you in a while. One of the finest realtors in all of South Florida, who I have known for a great many decades. Let's see. Easy Breezy says, fresh day 3 transfers in women over 43, previous cycles arrested on day 5. Love to hear your thoughts. Well, so here's the thing. When we talk about doing embryo transfers on day 3 versus growing those embryos to the blastocyst stage, well, the labs that grow to the blastocyst stage are kind of under the, go by the belief system that if an embryo is normal, it's going to grow whether it is in you or whether it is in the laboratory. But there are some people who feel that your uterus is always going to make a better petri dish than anything we have in the lab. So practices that grow embryos to blast and say, this is how we're going to transfer you, are doing that because they are using nature to help select a group of embryos that have a higher probability of being able to get you pregnant. If the embryo doesn't make it to that blastocyst stage or like a day 5 stage, that generally means that it is not a chromosomally normal embryo. So now other people think, well, but if you do a day 3 transfer before it has had the chance to grow to a blastocyst, then you are getting that embryo inside of you, and it may do better in you than it does in the laboratory. So maybe there's something about growth factors inside the uterus that make the uterus a better environment, and an embryo may grow inside of you that would not otherwise grow inside the laboratory. And that is one of the things that in women of what we'll call advanced reproductive age, and so you're mentioning by 43 years old, many of most, in fact, of the eggs that we're able to get from you at age 43 are not going to be chromosomally normal because, unlike the sperm that comes out today, that sperm is manufactured in his body 3 months ago. But every egg that you will ever have in your ovaries is there on day 1 of your life. And so over the course of our lives, as those eggs stay there, they have a chance to become less stable over time. That DNA becomes less stable, and we start to lose eggs just due to the process of maturing. Those are the two reasons that it gets harder and harder for us to be able to have a baby as we mature. Well, so one of the thought processes is, well, okay, look, if you're a little bit older, then maybe what we do is that we try to make as many embryos as we can anyway, but then we can transfer all of them. For instance, you could transfer 5, 6 day 3 embryos into a woman who is 43. And you can do that really safely for a couple of reasons. One, there's no way that all those eggs are going to be normal. It just statistically, I suppose it could happen, but it would be so highly improbable that even if you've grown to blast, the guidelines from the American Society for Reproductive Medicine tell us that at 43 you can transfer 3, 4 embryos if you want to, because they're not all likely to stick. So with the day 3 embryo, even more so, because many of those embryos, or at least some of those embryos, are not going to continue to grow. And so in that scenario, go ahead and put them in. Grow them to day 3 and just do a fresh transfer for as many day 3 embryos as you have. And perhaps you are increasing the probability that one of them will stick because you're putting them inside the uterus instead of letting them grow in the lab. Now, that's a controversial topic. Everybody doesn't agree with that. And unfortunately, we can't really interview an embryo to, kind of know whether it was going to, what was working or what wasn't going to work. We can't know that for sure. So it's kind of speculation. Many practices will say, no, we only transfer blasts because we only want to give you the best probability of pregnancy. But other people say, gosh, especially if you're older, transfer as many day 3 embryos as you have. Hi, Dale. Nice to see you this evening. We are live, by the way, from Tulsa, Oklahoma, where I am visiting with my colleagues at MCRM in Tulsa. Also, they have a wonderful office, the home office in Chesterfield, Missouri, in the St. Louis area. I am from Pensacola, Florida, and it's just so nice to be here with such great, really wonderful, nice people. Let's see if you're going to be around in about 7 minutes. We do the 5:30 Fuzzies with Fink, and that's a very important thing because that's the chance for all of us to send out some goodwill to everybody who needs it tonight, and we'll talk about that more in just a couple of minutes. Good evening, Sabrina. Thank you for being here. Can you explain exactly how letrozole works. I got pregnant with my first one with Provera and letrozole, but everything moves so fast. All I know is that letrozole makes me ovulate, and the answer is you got it, sister. The daily double. So, what's letrozole doing? Letrozole is so, we've got all kinds of hormones that are circling around in our bodies. Letrozole is a pill that you can take that blocks the conversion of testosterone. And yep, women have testosterone. It blocks your conversion of testosterone to estrogen. And most of that conversion, which has a name, it's called aromatization, like an aroma. I don't know why I call it, because it doesn't smell. But aromatization is the natural process where your testosterone is converted into estrogen, and that typically happens in our fat cells. Even people who don't have a lot of fat cells, it's always happening. That is a portion of where testosterone comes from through that aromatization process. Well, letrozole is what's called an aromatase inhibitor. It stops that reaction from happening, so it causes a little temporary dip in your estrogen level. Well, your brain is always on watch for how much estrogen you have. And when it sees that your estrogen level drops, it says, oh, we need to make some more estrogen here, don't we? And how does it do that? It increases its production of a hormone that's called FSH, follicle stimulating hormone. Because what does follicle stimulating hormone do? It stimulates follicles, and follicles are the little egg houses in your ovaries. That's where most of our estrogen comes from. Every little egg in the ovary is surrounded by some cells that make estrogen. And when the body sees that the estrogen level is low, it says, give me more estrogen. We need more estrogen. So that FSH hormone stimulates the ovary to produce an egg. So Sabrina, what happened there is you got some letrozole. Letrozole told the FSH in your pituitary gland to increase. The FSH level increased, which told your ovaries to make you an egg, or maybe even 2 eggs. And when they made those eggs, your estrogen level went back up and everybody got happy again. So that is a method of what we call ovulation induction. The Provera was designed to give you a period so that you could slough everything off, mow the grass, as it were, and be able to start again fresh. So it sounds like, Sabrina, your issue was that you weren't ovulating. You probably weren't getting periods. Well, so what happens is that we give you some Provera. So normally, let's say that your ovary does release an egg. Ovary releases an egg, hangs out, waits to get fertilized. If sperm comes along and fertilizes it, woohoo, all the bells go off, and that means, yep, I'm pregnant. Your brain says, do all those things you do when you get pregnant. And if not, the brain says, not pregnant. All right, fine. Well, shut off all the hormones, clean everything out, and let's start again fresh next month. And that's the signal to have a nice normal period. Well, how do you get that signal? That signal comes from progesterone. And so if your progesterone level is here and then it drops off, that drop off is what stimulates you to have your period. It's called a withdrawal bleed because you're withdrawing your progesterone levels. What Provera does is Provera is progesterone. And so it's giving you progesterone. You take it for a few days and then you stop taking it and your progesterone level goes down. And what happens? It triggers a bleed, just like in a natural cycle. So that's kind of how the letrozole and the Provera work, Sabrina. Great for folks who aren't ovulating. Got a nice words there from Jen Bader. Thank you so much. She says, love having you on the MCRM channel. And I love being able to be a part of MCRM because this is really, truly a special, special group of people. Smitty Rocks, good evening, and Pleasant Hill supporter, Jay Palmyro. Lamu here, good to see you. Hi, Mohai, nice to see you. And Jay Serrano, seeing all kinds of old friends pulling back over here. So, again, if you're just joining Creative Love Agency, hello, and thank you for being here. We've got a couple of different Instagram feeds. I'm Randy Fink. This is Randy Fink, MD. This is New Life Fertility. We have MCRM's Facebook, New Life's Facebook. We have LinkedIn. We have YouTube. If we should lose the feed here on the Facebook side, please do join in on the Instagram side until the top of the hour, answering all your questions about getting pregnant and making the family that we all desire. Hey, it's half past the hour, which means it's time for something special. I like to do this every week, and that is called the 5:30 Fuzzies with Fink. Because it's nice to be a little warm and fuzzy sometimes. It just really is. The world is not a friendly enough place. Every once in a while, I'll see a nice news story about, folks who did something that were really, really good and really nice. There is still goodness out there, but gosh, it's so easy to be overwhelmed by all the bad news that's on TV, especially now in these very, very challenging times. Well, when you're riding this fertility roller coaster, it is, as I like to say, it's the crappiest roller coaster in the entire park because it swings you this way and that way. It gives you a concussion. It makes you nauseated. You bang your head. Your glasses fall off. It hurts your neck. You wish that you hadn't gotten on that ride. But you're on it with no real guarantee that when that train pulls in the station that you're going to be able to get off of it with a lovely parting gift like a baby. The fertility roller coaster stinks. It's no fun. It hurts. There's pain involved, both physical pain and, more importantly, emotional pain. There's uncertainty. There is a feeling of, gosh, I want this so bad that I can taste it, but somehow it is eluding me. It's just out of my reach. And with everything that we do in the fertility world, we're trying to bring that dream closer to you. But it's frustrating. It's frustrating at almost every turn. I know that most of the folks who watch this broadcast are a very kind group of people who would really do anything to be able to help others around. Not just in the fertility sense, but many out there are going through hard times now related to problems with family, related to problems with school, related to problems with relationships. This is the chance for us all to stand together as one community and send our well wishes out to everyone tonight who is in need, to all those who have a family member who is sick, to all those who have recently lost someone or maybe lost a pregnancy, to all those who don't know what tomorrow has to hold for their fertility as they're on this journey. And do any of us really know what tomorrow has to hold for our lives? This is our chance to break the internet, friends, and send out those positive vibes to each and every one of us. Do that right now, if you would. Imagine us all in one big kumbaya group hug, because that's what it's all about. You, my friends, are not alone on this journey. We are here with you every step of the way. And no matter what challenges life throws at you, we are going to get through this and we're going to do it together. You are not alone. As I'm fond of saying at the end of the broadcast, every day forward with hope, because tomorrow is a new day full of all new adventures. And that is the 5:30 Fuzzies with Fink. Thank you for participating in that. Hey, if you would, ask your friends next week if they can hop on at like 29 minutes past the hour, just for 2 minutes, if you could, because the more people that we can have here at that 5:30 mark, the more really impact I think we can have on the world by sharing this really important sentiment. I think it's so important for everyone to know that they're not alone. Jen Bader says, dream one size too big and find joy in the journey. And I will tell you there's absolutely some truth to that. And those, who have kids now will be able to kind of tell you the same thing. Um, when the kids are little, um, um, gosh, you don't sleep very well. Your house is a mess. There's toys everywhere. Um, um, Feeding is a hassle. Diapers are a hassle. It takes forever to get out of the house and to try to get someplace. Traveling is a wonder all itself that you're able to get through it. But each and every one of those days is so precious because when your kids grow, and I've got 18, 17, and 13. My kids are 18, 17, and 13. And it's so hard, even on a daily basis, because I still, in my mind, are rocking them to sleep, even though one's in college and one is a high school senior. Those days go by so fast. So, yeah, find joy in the journey and treasure each and every day and each memory, because my friends, the time goes by like you really just couldn't believe. Hey, Sheila, nice to see you here this evening on the New Life side. If you're just joining, my name is Dr. Randy Fink, and this is Fertility with Fink. We are here every Tuesday evening at 5 p.m. Central Time. I'm from Pensacola, Florida. Tonight, we're live from Tulsa, Oklahoma, where I'm visiting with MCRM Tulsa. So wherever you are this evening, know that we're here with you, here to answer your questions, and we're available to you at any time for a consultation on your journey here. So thanks again for being here. Let's see what else is going on. Rosa asks, let's see, I had a 3.5 centimeter endometriosis cyst in my ovary before pregnancy. Does breastfeeding have any effect on reducing its size if I breastfeed for a year? And the answer is, yeah, it may very well, Rosa, because when you are breastfeeding, you are suppressing your hormones. So, I have always been kind of fond of thinking about one of the best treatments for endometriosis is getting pregnant and having a baby, because when you're pregnant, endometriosis gets suppressed, and then you go to have a baby. If you're breastfeeding, that at least turns down the hormone levels and may just kind of turn them off entirely. So, yeah, I would think that there's a realistic probability that if you're breastfeeding, that you may find that endometriosis cyst does indeed get smaller. So, yeah, how about that? Zinni, good afternoon in Miami. Thank you so much for being here. Hi, Noodles for Life and Expecting Ish. Liz Carmen, it's good to see you here as well. And Mo, and let's just say Miss Amal. Mohai, I never know how to pronounce it, but Mohi Amal says, Doctor, I had my first embryo transfer the day after Christmas, 12/26. We transferred day 3 embryos, and I didn't get pregnant. I am starting a new transfer tomorrow. What suggestions do you have for me? I am 48 years old. So the issues there, my friend, really relate to the embryos themselves. And as we were just discussing, one strategy is to create as many embryos as you can, because at 48, to be honest, the odds that an egg that you would produce in your ovaries will be normal, the odds of that are very, very low. So, first of all, you're in a good place because you're actually able to make some embryos from that. So that's great news. So I don't think that there's anything necessarily about a transfer protocol when we're 48 years old. I think the issue is trying to maximize what we have in terms of embryos, knowing that the majority of the embryos we will be able to make are not going to be normal. So what we're doing is playing a math game. It's absolutely a numbers game to get, the right egg to make the right embryo, because it only takes one egg to make one embryo to make one baby. And but honestly, at 48, it's going to take many eggs um, um, to find the one egg that is going to be normal. So I think you did the right thing. I think it's fine to go ahead and transfer to do day 3 embryos at 48, because let's get those embryos back inside of you, really where they belong. And if something is normal, it's going to stick. Now, the other thing I would say is that there are typically 5 supplements that are recommended as part of the embryo transfer protocol. Um, and by the way, hi, Lisa. If I didn't say hi, nice to see you this evening. I skipped over you there. I'm so sorry. 5 supplements. What are they? Your prenatal vitamin. Okay, that one's easy. By the way, I've found myself saying this several times today, and I just kind of want to repeat it to everybody about a prenatal vitamin. And that is that don't overspend on a prenatal. You can go to the internet and you can see there's this, $120 prenatal vitamin, and you could say that one must be really good because it's so expensive. I'm going to take that one. And I would say most of that vitamin ends up in your urine. So don't overspend on the vitamin. There's really not substantially a lot that's different in that regular prenatal than you might find in a $6 Walmart gummy. So don't overspend on your prenatal vitamin. The most important thing a prenatal vitamin has in it is the folic acid. 400 micrograms of folic acid is the recommended dose of folic acid. Some vitamins have 800 micrograms of folic acid. Some have 1200. Guess how much you need? 400, and that's it. Some vitamins have a coating, so they're tolerated a little bit better. Some of them have some iron. Some of them have a little stool softener. Some of them have some more B vitamins. There's some little nuances about this and that. But substantively speaking, what I always say is that if I could tell you that your prenatal vitamin, if you spend $100 on it, your child is going to become president of the United States. Your child is going to go to Harvard on a full scholarship. Then scrounge the $100, because that vitamin is worth taking. But vitamins don't do that. So please don't overspend on a prenatal. Anyway, I got a little bit sidetracked there. 5 supplements, evidence-based protocol for embryo transfer: prenatal vitamin, vitamin D, vitamin E, CoQ10, and L-arginine. L-arginine. Now, all of those, except for the L-arginine, are recommended things to take for egg quality in an IVF cycle, or even in someone who's just trying to get pregnant through other means. That's part of the evidence-based protocol. Dose may be a little bit different, but the L-arginine, don't take that if you're trying to get pregnant, because it can have some negative effect on egg quality. But it is absolutely part of the protocol for embryo transfer. The one other piece is that if you have a history of endometriosis, the recommendation is that you add 1,000 milligrams of vitamin C to your protocol. I've got some nice vitamin C in my bag over there right now, because I tend to kind of want to take it when I'm traveling. Mega dosing on vitamin C, taking 1,000 milligrams a day, kind of when you're on the road or around other people who are breathing their flu and COVID germs and that kind of thing on you. I don't know if it really makes a difference, but it makes me think that it makes a difference, and so therefore it makes a difference. But from an endometriosis standpoint, 1,000 milligrams daily of vitamin D is part of the recommendation for embryo transfer. Let's see. I think I had another little question over here. Did I miss it? No, I think I got that. Mohi says, thank you so much. Can you tell me exactly how to pronounce your name? Mohai, I don't know. And I always feel bad, because I always want to tell you hello, but then I feel badly for for mispronouncing your name, and that just isn't right. It's just not right. What else can we talk about here tonight? Amal, yes. What's the first word? I got the Amal part. Um, oh, Amal is your name. Okay. Well, what's Mohi or Mohai mean? I don't know. Um, well, but thank you anyway for being here. I wanted to talk about something else that seems to come up some of the time. And Mohi is your last name. Oh, I got it. So we got them switched up there. I wanted to talk a little bit about some of the immune system things that we look at. So when we talk about things like what we call unexplained infertility, what really is unexplained infertility? Well, the technically the definition is unexplained infertility is when we can't find any other reason that you have infertility concerns. Well, okay, is it really truly unexplained? In some cases, I think endometriosis, undiagnosed endometriosis, has something to do with unexplained infertility. Nowadays, we can make the diagnosis of endometriosis without having to have surgery. In the past, you would have been scheduled for a laparoscopy before you ever even saw the doctor. Everybody got a laparoscopy as part of the routine workup for infertility. And nowadays, we realize that's just not necessary. There are a lot of docs who still feel strongly about the laparoscopy and want people to have laparoscopy. Endometriosis can cause a pain syndrome. It can cause some scarring issues, some changes in the anatomy inside. But endometriosis, when it can interfere with the hormones, but we know that endometriosis also really can cause a problem in the way the embryo implants inside the uterus. And we think the way that happens is because it starts to fight against your progesterone. So the BCL6 marker, which can be tested through a test that's called Receptiva. It's a non-invasive test. It's an endometrial biopsy where we suck a little piece of tissue out, and we can tell you pretty accurately if you've got endometriosis, because even though the pain syndrome is the most common, is the presentation we're most used to seeing and hearing about. In fact, probably the most common presentation is silent endometriosis, and that's when folks have endometriosis and they don't even know it's there. So the thing about the Receptiva test, I will tell you, is that, insurance doesn't cover it. And some people say, oh, well, if my insurance doesn't cover it, then I don't want to have to do it. Well, so why doesn't insurance cover it? Well, if you've paid any attention kind of to the news or to really even any of the escapades that you have with your own health insurance, insurance is not there to protect you. It's a very strange business model, health insurance, because they are for-profit companies, and the only way that they make money is by maximizing the amount that they collect from you in terms of fees, and minimizing what they have to pay out on your behalf. There's been a wonderful series on NBC that is, it's called The Cost of Denial, and it's usually on NBC Nightly News, and they talk about the cost of denial, what, different cases where health insurance denies people care, denies people, life-saving cancer treatment. There was one the other night denying someone her prosthetic foot, even though she had one for many years, and then it wore out and they wouldn't give her another one, and when they get called out on it, they usually back off and change their tune. There's a lot having to do with kind of breast cancer treatment. Insurance companies aren't there to help you. They really aren't. And so what happens is, since there is only one laboratory that can do this BCL6 test, this lab has said, we don't have any competition. There's no reason for us to take insurance with this. Let insurance push us around and tell us what our test is worth and only what they'll pay for it. We're not going to do it. But it turns out that, let's say that you had to have surgery. Let's say that you had to go and have a laparoscopy. So that means, one, you got to risk general anesthesia. You got to have sharp implements placed through your belly button to the inside so that somebody can look around. And with all of the deductibles now are outrageous. And then you got copays on top of it. And then anesthesia wants their copay and deductible. And then the pathologists want theirs. And then the surgery center wants theirs. All this and that, all in. A surgery like a laparoscopy that is going to be covered by your insurance may end up costing you thousands of dollars, even though it's covered by your insurance, compared to what I think the $695 is for the Receptiva test. So I'm pretty sure that's probably how they came up with that pricing, to think of, well, what does it take? What is this actually really worth, and what are people able to save by not having to do that surgery? Endometriosis is one thing, and the immune system is another. We have all kinds of things that we can do for the immune system now, and we're happy to talk with you about those. And if you have any questions, throw them out here. Angela asks, can you recommend a good sperm bank? So the California Cryobank is very, very popular. The Fairfax Cryobank is also very, very popular. We see a lot of folks using those banks, and I know they are at least very reliable. Jay Serrano says here, if my one fallopian tube is blocked, but I had a chemical pregnancy, does that mean sperm was able to meet egg and push through the blockage? The HCG was below 25, and then it was 0. Okay, so here's what happened. You had what we know of as a biochemical pregnancy. You had a positive pregnancy test, evidence of the pregnancy. Now, we don't know, Jay, where exactly that pregnancy was. Could it have been a pregnancy that was in the fallopian tube? Yeah, it could have, and then it just ended really on its own. But is it also possible that sperm and egg, and remember, they're not very big, they're very, very tiny, and all they need is a microscopic little tunnel to be able to get through? Is it possible that sperm and egg met each other and traveled their way down to your uterus? And the answer is, yeah, absolutely, that's possible. That definitely could have happened. The problem is that unless you can do an ultrasound and see where that pregnancy is, there's no way to know for sure. Was it actually in the tube, or was it in the uterine cavity? Now, when folks have a blocked fallopian tube, depending on how that's diagnosed, sometimes that blockage is really just what we call a tubal spasm. And that's when we push some fluid into the uterus. Let's say you're doing the dye test, the HSG, and it can cause the tube to spasm, which means that, well, the tube may actually be open and normal, but for whatever reason, they're going like that because they're kind of getting inundated with fluid. And that can give you a false positive that the tube is blocked. In fact, it is said that up to 60%, 6 out of 10 people who show a blocked tube on an HSG are actually experiencing a tubal spasm, and the tube really may not be blocked. So if you want to know for sure, well, you can always repeat the HSG, but the HSG stinks. It's an awful test to have to do. It's no fun. It's painful. It's expensive. So usually by the time that we see, okay, it looks like tubes aren't working or one tube isn't working, then we say, all right, this HSG was real. Other ways you can do that, you can do it under general anesthesia with, pardon me, with a laparoscopy. and Jay, you did the HSG. Um, so I would say, yeah, there is absolutely a chance that tube may at least be partially open. So, hey, congratulations that you got pregnant. I guess that was a spontaneous pregnancy for you, and I'm really happy to hear that because, pardon me, if you did it once, then please do it again, would you? Um, good deal, and fingers crossed over there. Well, folks, we're going to run out of time for the broadcast this evening, but we will be back next week live from Pensacola, Florida. Again, happy to see you no matter where you live at New Life Fertility or at MCRM. Live tonight from Tulsa, Oklahoma. It has been a real pleasure to be with all of you. Thanks for participating in the Fuzzies with Fink there, and please join me next week for that again. You know, this fertility business is not the book of your life, it is just a chapter. And what are we doing? We're here to rewrite that damn thing. So let's do that together. Every step forward with love, every step forward with kindness, and every step forward with hope. Because tomorrow is a new day full of all new adventures. So until next week, Dr. Randy Fink saying thanks for being here and good night.